Yeah, hi, Tania. It's really nice to meet with you. Thank you for that kind introduction. Now, I request the host to enable my video.
Okay, a moment. Could you give it a go now, Prof? Oh, there we are.
Super. Yeah, now I can. Yeah, right. So, good afternoon, everyone. Before I really get started, I want to try and share my screen.
Sure. I think you can now. I think, Nelson, if you could stop sharing. There we go. All
right. Super. Okay. All right. So, hi, everybody. I'm just really, and I really want to appreciate the organizers of these seminars for inviting me to talk about this topic on this special day today. In case you didn't know, today is the World TB Day, and it's a day when the whole world gathers to remember the huge problem of TB that remains a global problem, and we gather together to strategize on how to win against this terrible disease. Yeah, so I want to just I'm going to spend maybe about an hour talking to you about different key issues on TB in children. It's not just children. By children, I mean up to 17 years, you know, the child and the teenager, the children and the adolescents. And I chose to call this TB in children, the battle continues, because I think in Kenya, we have been really, over the last 10 years, we have been really working hard, all of us in different places, and especially the National TB Program. We've been working hard to try and improve our handling of children, all things that are child TB. And let's see if I can move this slide. Okay, so this is our 2021 Global TB Report. And you can see that TB continues to ravage the whole world. It is the single most chronic infectious disease that it is the one chronic infectious disease that causes the highest burden of morbidity and the highest deaths. And this is like more than 50 years after we got effective TB medications. So globally, if we look at the total, we have 10 million people infected, 10 million people sick with TB. But if you look at children, we have 7.5 million children who get first infected, who get primary infection each year. And out of those 7.5 million, about 1 million children were reported to various health programs to be sick with TB in 2020, okay? And half of these kids were below 5 years old, and adolescents were not left out. So these are the really sobering statistics that we're dealing with on a global level. And of those 1 million, you can see that deaths are very high. We'll look a little bit more at it. Let's come back home to Kenya. Looking at this map, you can see every place, the darker the color, the darker the country, the higher the burden of TB. And as you can see from this map, Kenya is still dark green. We continue to have that dubious position of being among the top 30 countries in the world with high TB burden. So TB continues to be a huge problem for us in Kenya and indeed most of sub-Saharan Africa. If you look a little bit deeper within Kenya, you can see that there's no county that is spared. TB is present all over Kenya. And the darker colors show you the counties that have a higher TB burden. But even if you look a little bit lighter, it doesn't mean that things are good. You can see the majority of Kenya is either dark orange or yellow. And the counties, this is from our national, our annual the National TB Program annual report, and it showed that they actually brought out 5 counties that have the highest TB burden, and you can see them shown over there. So Mombasa is at the top, followed by Tharaka Nithi, Turkana, and others, the remote areas, Mandera and Wajir and Nandi. So you can see we still have a high burden here in Kenya. Now, if I go back to the global picture, I'll keep moving between the global picture and then what are we seeing in Kenya? On the global picture, Kenya has is among the few countries that has gotten our act together, and we have developed data systems where we actually record the age of every child who's reported to us. And so this didn't used to be the case 10 years ago or even 5 years ago. So Kenya is now able to, from their data, tell you how many children under 1 year, 1 to 2 years, below 5 years have had TB. And it's only 13 of the 30 high burden countries that are actually able to do this. And you can see Kenya is among one of them. So I really congratulate ourselves collectively. And from the Kenya data, you can see this blue line here is Kenya. Who is the most affected? Where do we see the largest number of cases per 100,000 of children? You can see this number is 0 to 4 years, and we have more than about 45 cases per 100,000 children under 5 diagnosed with TB. And if you come to 5 to 9 years age group, it drops, but you still have a significant number in the 5 to 9 year age group. 10 to 14 year age group, we begin to see an increasing incidence. And the worst hits are the 15 to 19 year old age group, where you can see it's shot up to 60, almost 70 cases per 100,000. So you can see that our biggest hit groups are the children under 5 and the children 15 to 19 years, but we get TB in all age groups. This is really helpful, so that we must remember that when children come in sick, we need to suspect TB where the symptoms and signs are suggestive for all age groups. And coming now to the annual report, Kenya's annual report 2021, where the reported 2020 data, here are the absolute number of TB cases that were reported. And this beautiful graph shows us, okay, females, males, but 0 to 4 years, we had approximately 1,500, about 3,000 cases in 2020, okay? And remember 2020 was a COVID year, huh? And then 5 to 9 years, we had this amount. Then again, you see the same thing in the 15 to 19 year old, we see a huge number. Females here and males seem to be having a higher burden. So this gives us a real good picture of TB across the spectrum of children and teenagers in Kenya. Now, if we look at these children in during the year 2020, I think what I want us to appreciate here is that we are really good at doing our nutritional assessment once we make a diagnosis of TB, and we found that a quarter of them present with severe acute malnutrition. We call it malnutrition, but it's in majority of them, it's probably not food deprivation. It's in a large proportion of them, it's probably just the classical weight loss, wasting, that is a clinical feature of TB. So 24% of them will might be diagnosed as just having malnutrition and severe forms of malnutrition. And if you put the moderate together with the severe, you can see that 1/3 of the children who are notified in that year presented with either moderate or severe malnutrition. Okay. Now this graph up here shows the picture over 5-year period. And in Kenya, actually, I've been working, I interact a lot with the National TB program, and there've been a lot of initiatives and a lot of interventions to improve our ability to detect the child TB cases. And you can see 2016, 17, 18, our case detection really improved of children. And our highest was 2018 with 10,000 cases actually notified. But in 2020, we went from 10,000 down to 5,000. Doesn't mean that there was less TB, but COVID, I know a lot of kids probably just didn't make it. They didn't make it to there was shutdowns, there was lockdowns, there were curfews. Anybody coughing was highly stigmatized, So, I think we can see that in 2020, we really took a step back and we lost some ground. So that's the Kenya picture, that's magnitude. Now, having given those numbers, I think one thing we need to appreciate is that those numbers do not represent the full picture. Globally, from various modeling studies and actual community surveillance studies, they found that the actual number of children reported is really a small is only a subset of the true full number of cases. And in this global data, you can see that we are missing cases in the 0 to 4-year-old age group. Only a quarter of all true TB cases under 5 actually get notified, get detected and started on treatment. 3/4 of the children under 5 who have TB just don't make it to our health facilities, and we don't know what happens to them. And the same gap is 5 to 14 years. 5 to 14 years, you might think that, oh, it's easier to get them. Maybe they might be able to give out a sputum. It might be easier to make a diagnosis. They're more likely to have bacilli in their sputum, but we're still, even globally, and we're not alone globally, about only 45% of children 5 to 14 years actually get diagnosed, and half of them just never get detected. So there's a huge case detection gap. And this gap is less for adults, or those above 15%, we still miss some cases, but at least it's better. This is a global map that tells you how we are comparing to the rest of Africa. And I find this map extremely informative. So just in keeping with the previous slide, in Kenya, this shows the missing child TB cases in the 30 top high burden TB countries in the world. And the red number is an indication of the percent of all child cases under 14 that we miss. And you can see Kenya in this year, this was about, I think, a year earlier. This is the year we did a little bit better. We missed 67% of the cases. And if you look at the rest of Africa, 70, 80, it's only South Africa that's down to 50, but in all sub-Saharan Africa, we're missing a lot of cases. And most of so 67% of children 0 to 4 years. Now the blue is the children 5 to 14 years that we're missing. So you can see across the age band, we are doing badly. And this is seen throughout sub-Saharan Africa. So we really still have a battle ahead of us. And just to bring back to our understanding, really what was the impact of COVID on TB notifications. These are the global data for all TB notifications, child TB notifications in 2020. And you can see from 2011, actually from 2013, things really improved up to 2019, but 2020, we had a huge drop of notifications all over globally. Okay, and so you can see it dropped by about 25% globally. And that's what I showed you in the previous slide in Kenya, how we experienced a similar drop. All right, so now I want to just look at the magnitude and the burden of the TB HIV, the children living with HIV who are co-infected with TB, 0 to 14 years. So the global picture, this shows a nice, the cascade in terms of all kids who have TB, what proportion of them get an HIV test, and among those who get an HIV test, what proportion of them actually are HIV positive. So you can see out of all TB, this is globally, of all kids 0 to 14 years who are diagnosed with TB, globally about 68% get HIV tested. And among those who are tested, the HIV positivity rate is 5.4%, okay? So this is based on data from 38 countries. And then globally, it looks like once you do get you do make the HIV diagnosis in children globally, we are pretty good at getting them onto antiretroviral therapy. How's the picture in Kenya? So this is the same data, but now coming home to Kenya. And in Kenya, I must really, I must commend all of us and the National TB Program and all of us who are involved with, when we diagnose TB in children, in 2020, we were able to test 96%. This is higher than the 85% we saw in the previous slide. So we really are doing well in doing HIV testing. And what was the positivity rate in Kenya? Among the children who had TB, 14% were HIV positive. And you can see this is higher than the global average. The global average was 5.8%. So we still have a lot of, among 100 children who have TB, 14 will be HIV infected. So on the flip side, you have to keep your eye out for HIV, but on the other side, you have to recognize that actually majority of children with TB, 86% of them do not have HIV, okay? All right, and then we get our ART uptake is very, very high. So I want to draw your attention to a review article that a group of us published last year on HIV-associated TB in children and adolescents. And it's a really nice overview of various aspects of HIV-associated TB in children. And there's not enough time for me to go through some of the gold nuggets that we shared, but I encourage you to download this article and take a look. But here I just picked one table where you can see in a study by Videlis Nduba by KEMRI, a prospective cohort study of 2,900 infants who were born without HIV negative infants. They looked at the risk of them getting TB compared to, they compared the risk of getting TB, and they found that the infants who had TB had five times higher occurrence of active TB disease compared to the HIV negative. So when you do have HIV, your risk, those children are a much higher risk of getting TB, but there's much more in that paper. Okay, so once we have made the diagnosis of TB, how are we doing in the outcomes? Oops, how are we doing in the outcomes? And this is just an overview, again, in the 2019 cohort of kids. I've moved away from the 2020 because of all the distortions from COVID. Our success rate, once we get these kids onto treatment, we have very high success rate. Success rate means they complete their 6 months of TB treatment and they're alive, and we discharge them from care. So our treatment success rate was 88.6% from that cohort. And this compares favorably with the global average. Now, very few kids get confirmed bacteriologically in Kenya, very few kids get confirmed bacteriologically in Kenya, usually it's about 15%. But among those, and it's usually the older kids, the teenagers who are sputum positive, the cure rate is a bit lower. And this is a bit worrying, eh? The teenagers. The cure rate, that means we take a sputum towards the end of treatment and we find that the sputum has turned from TB positive to TB negative, cure rate is only 66%. So I think this is something that we need to watch, where we get a sputum positive child we really have to make sure that we have strategies to make sure that they keep on their treatment, they complete their treatment, and they get cured. Our mortality rate overall in kids under 14 was about 4.8%. So 5 out of every 100 died. To me, that is still high, but it's better than what it has been in the past. Okay, now 18 counties had higher higher death rates above that 5%. And I've just listed 5 of them here. Taita Taveta, it was 8 out of every 100 kids with TB died, and you can see this is a bit unacceptable because TB is a curable disease. And as I said, this is still an underrepresentation. The 3/4 of kids never even get to us. We never make the diagnosis. So there may be many other children who die from TB in our setting before accessing TB treatment. So this is likely an underestimate. And going back to the global picture, they've highlighted from global figures of the 1 million kids who got TB in 2020, 250,000 of them died. That is really 25% of them died globally. Why are they dying? And TB treatment is available.
Prof? Prof, you're on mute.
Hello? Can you hear me now?
Yes, we can.
Okay, sorry, my Wi-Fi is a bit dodgy. So I was just trying to bring out that globally, of the 1 million children who got who had TB, 226,000, 250,000 of them died. And who were the most vulnerable? The under 5s. Actually, of all the deaths, 80% of the deaths were kids under 5 years. And 96% from these estimates were kids who never even got access. They were diagnosed, but they really didn't get access to the TB treatment. And then, of course, a significant number of the deaths were children living with HIV. So children are still dying from this dreadful disease, which is treatable. This is really unacceptable. Now, if we then talk about prevention of TB, I want to here show the global data on prevention.
We can't see your slides.
Okay, sorry. Looks like I have to share again.
Yeah.
Okay.
Excellent. We can see them now.
Okay. So this slide you were able to see, I trust?
Yes.
Yeah, so in this slide shows the 250,000 deaths, and 80% of the deaths were under 5s, and then majority of kids who died didn't really get TB treatment, and a lot of the deaths were children living with HIV. Yeah, so here we are showing what's the situation in terms of prevention of TB. Yeah, it's much better to prevent these kids from getting sick with TB in the first place. So how are we doing it? When this globally, of the child contacts under 5 years who were exposed to an adult with TB, only 35% actually access TB preventive therapy. This is really, really low. This big bar is the number of kids that are the contacts of adults with pulmonary TB, smear positive pulmonary TB. And you can see the dark blue is the percent. So we're really doing badly. We could prevent these kids from getting this dreadful disease, but we're really doing badly globally. And Of course, with COVID, things got even worse. The number of TB notifications went down, so we don't even know how many other contacts. The total kids initiated on TB preventive therapy dropped in the COVID year, and there are many who probably just, they are now the ones who are coming to us with active TB disease. So there's a huge prevention gap. Almost 2/3 of those who are eligible did not access the TB preventive therapy. And what's the situation in Kenya? Our target in Kenya, which is interesting, is to try and reach, of all adults who are smear positive, our target was very modest. We try and reach at least 1/3 of their child contacts. That was our target. And we reached about, so we want to reach, you want to reach the child contacts of 1/3 of the adult cases, okay? We achieved 61% of that target. So 61% of the 1/3 of adult cases. It might look nice if you say 61%, but the true picture is really, we should look at all adult cases. Rather than 1/3, we should look at all adult cases. So that tells us that the true picture is that we reached about 20% of all vulnerable children under 5 who were in contact with adults with TB. So TB prevention, we're missing 80% of the vulnerable kids. We're missing it's a huge gap in terms of preventing disease. And you can see over the years, we have been struggling to improve, but remember our denominator is not even all TB cases, it's just 1/3 of adult TB cases. So this is really, we still have a long way to go. Now, if I want to take you now to our global targets. The United Nations Global Assembly sits every few years and sets global targets. So the global targets here that were for the period, our global targets were set for how many we should detect or make a diagnosis and treat a certain number of 3.5 million kids. And we only succeeded in doing 40%. Our target for drug-resistant TB was that we should reach about 115,000 globally. We only reached 10%, okay? For TB preventive therapy, you can see we only 29% of the target globally. Okay, this is children under 5 who should have been initiated on TB preventive therapy. And in 2018, the WHO guidelines expanded the eligibility for TB preventive therapy to children over 5. Actually, in 2018, this was a major policy change where we said children above 5 years, if they're in contact with an adult who has smear positive TB, should be considered for TB preventive therapy if for any reason, as a pediatrician or as a doctor or a clinician, you think that this child above 5 years is eligible. And we haven't even started doing that. I think the under 5s, we just leave them and assume they'll be okay, but the reality is they are not okay. I'm sure many of you see enough of the children above 5 years coming with bad TB pleural effusion in the ward, etc. Okay, so we are really not achieving we set nice targets, and we have been trying to have various interventions to improve our handling of children and adolescents, but we're still far. The only target that we really did well here is with children living with HIV. And the children living with HIV, we have even superseded our target. Most of them have gotten their TB preventive therapy, which is a great thing. So what's the situation? So I think that first section of this lecture has taken you through a sort of an overview of the epidemiology of TB in children and adolescents globally and back here at home in Kenya, and how well we're doing and where things are not going well. So as you can see from that overview, the battle against this dreadful disease really continues. So how are we going to strategize to win this battle? This is a nice sort of road showing the pathway of this child. This child is the little one here in red. The pathway of this child as they walk through life. So this is the child, she's susceptible. And then she gets exposed to somebody within her community who has TB. And from there, TB settles in her lung, she gets infected, and she might be able to contain it. But if they're young children, as you can see, many of them will not contain it. Okay, if they access the health system, if we screen them early, we might give TB preventive therapy and prevent them from getting sick with TB. But the reality is that many of them don't access the health system. So there's a gap there, and they just are there in the community at home being treated with amoxil, and they die, okay? Or they survive and they manage to get to a hospital and they're feeling sick, but we don't diagnose them. We don't diagnose them correctly. And if we do finally diagnose them, they end up having sequelae, severe sequelae, either TB meningitis with cerebral palsy, or they get damaged lungs, etc. They get bones and they get spinal injury, if we diagnose them too late, okay, and they get disability, or we just don't diagnose them and they die. Of course, there will be some who actually we diagnose and treat them, and these are the happy story. So with this pathway, it really gives us a picture of all the places where we have gaps. We can intervene to take prevention, prevent this disease. We make the diagnosis in adults. So from there, it is very easy to just go and look for their child contact or tell them, bring your children, we assess them, and your children, bring them. They're at risk because you've been coughing this bacilla in the house. We can prevent them from getting disease. So we should prevent and put our energy into the two main interventions we have for prevention is the vaccination and the chemoprophylaxis, okay? I want us to revisit BCG vaccine. I had the opportunity to be part of a World Health Organization, what they call a SAGE group, Strategic Advisory Group of Experts in 2017, 2018. And it was a really intensive exercise where we looked at all the literature we could find on BCG vaccine to help us understand, what do we really know about BCG vaccine? Is it still good? What is it able to do? What is it not able to do? And so from that exercise, this is one of the papers I reviewed. You can find you can find our comprehensive report in an MMWR communication. I forgot to put the reference here, but if you just look at the BCG vaccine, whatever review by the WHO team, you'll find it has a lot of nice summarized information. But one of the most powerful papers that I saw was this meta-analysis. Okay, now this systematic review and meta-analysis. So previous evidence, we have always believed that BCG, all it does is prevent kids from getting severe forms of TB. That's basically what we've believed. From the time I was in medical school to postgraduate, we've always said it just prevents severe forms of TB, but it can't prevent mild pulmonary. If you get pulmonary TB, you'll not get a severe form. If you get, so that's what it was. That's what was previously thought. But from this meta-analysis and a lot of emerging data, it seems that BCG does even more than that. Okay, so this was a meta-analysis by Roy et al. Sorry, oh dear. Okay, so so this was a systematic review. It included 14 observational studies, involved about 4,000 kids across 4 continents in high TB endemic settings, low TB endemic settings, varying TB epidemiologic settings. And in this, to be included, the study had to have looked at child contacts of adults with confirmed PTB. And then those child in the studies, the child contact should have been screened for TB infection, either using IGRA, either ELISpot or quantiferin assay, or they should have been screened for presence of active of TB disease. So there were 14 studies, 4,000 kids. And this is what they found. So this is what we call a forest plot. And you can see all the 14 studies, the number who are vaccinated, who got TB. For example, here it's 130 out of 467 of the vaccinated ones got TB. And of those who had never had BCG vaccine in this particular study, only 68 had never had BCG vaccine, and 16 out of the 68 got TB. And then you create an odds ratio. So if you had not been vaccinated, your odds of getting TB here, your odds comparing the ones who are vaccinated to the unvaccinated is shown here. So you can see most of them, if you had BCG vaccine, yeah, you fall on this side. And this is a sort of a pooled, what they call a pooled risk ratio. Getting the average of all these risk ratios, it's found from all those kids, the risk of getting AGRA positive, that is getting TB infection, if you had BCG vaccine, was 0.81. So from this forest plot, this meta-analysis, it meant that those who had BCG vaccine had 19% less occurrence of TB infection, of being AGRA positive, compared to those who never got TB vaccine. So this was the first sort of insight and high quality evidence that told us that actually BCG vaccine, it may look modest, but reducing, having out of 100 kids, simply by vaccinating them, 20 kids will not get, they may be exposed to an adult with smear positive TB, but they won't get infected. The TB will not take root. So this was new. So it reduces TB infection. And then he looked at, so that previous slide, there was a mixture of cross-sectional studies and cohort studies. So he now then looked at 6 prospective cohort studies that actually they followed up these child contacts. So you have your adult with smear positive TB, you enroll the child, you do AGRA and follow that child up for a couple of years. And over that period, you check whether this child gets incident TB infection, if they're AGRA negative turns positive, or if they are AGRA positive and then they get sick. Okay, so these are 6 cohort studies that gave us really interesting insights. So you can see the 6 studies, and here was the data on whether they turned from AGRA positive to AGRA negative to AGRA positive. Okay, the incidence of new TB infection after the contact, and this shows the risk of getting active disease, active TB disease in the period of follow-up, etc. So in summary, what did they find? They found from cohort data, which is more powerful, that actually infection is reduced by even more. BCG reduced infection by 27%. So among 100 kids who were exposed to an adult with smear positive TB, followed up for a couple of years, 27% of them did not get infected with the bacilli. The second major finding here, and you can see the pooled odds ratio, is that among all the kids in these studies, 71% of them, it reduced the risk of them getting any type of active TB disease, whether it's pulmonary, extrapulmonary, etc. It reduced the risk of them getting any kind of active TB disease by 71%. So this was really another new finding. And then among those who got newly infected, it prevented them from progressing to active disease by 58%. So BCG vaccine, you can see, has a huge impact in preventing TB, in preventing active disease in 3/4 of them, and in preventing incident infection and active disease in 58%. So from that meta-analysis, and there's other data, other meta-analysis that are available, it gave us really, it was encouraging. BCG is an old vaccine, but it is making a difference. So we are right in Kenya in vaccinating. We say every Kenyan child who's born, give them the BCG vaccine within the first day or 2 of life, and it is making a difference. Otherwise, we'd be in a worse status with our kids. Now, the next paper the next systematic review that gives us more confidence about BCGs. This guy looked at how long is the duration of protection from BCG vaccine. And this meta-analysis he looked at, I think there were about 6 or 7 studies, where they had followed a group of people for more than 10 years from the time they got BCG vaccine, and followed them for many years to see if they get TB. And so then, as you can imagine, this is a very expensive study. So there are not too many in the world, but it did provide some initial insights. So in this, you can see I've circled here, during the first 10 years of follow-up, here are the figures of the vaccine efficacy. That means this is what percent of people were protected from getting incident TB. And so you can see in the first 10 years, it's this figure, and then after 10 years, it's this figure. So in the first 10 years, the protective effect was 81%. Then after 10 years, the protective effect seemed to drop a bit, 50%. And this was seen across all the studies. You can see 30 to 26, 83 to some of it, really, the protective effect was lost. Okay, so it shows that it looks like that. So their conclusion is that there's good evidence that BCG vaccine protects against pulmonary and extrapulmonary TB for up to 10 years, okay? But the strength of that protection appears to decline with time. Now, there was only one trial that has followed the participants up for like several decades. And that trial suggests that BCG vaccine may protect against TB beyond 15 years, but it's just one trial, so there's limited data. But it's encouraging that at least it seems to protect somewhat beyond 15 years. The absence of more studies shouldn't make us decide that there's no effect, but on the other hand, we're not sure. We really don't have data to know how long is this protective effect from BCG vaccine. Okay, so that was, I've taken some time to emphasize to you that really BCG, vaccinating our kids is really important. It's protecting and reducing the infections, reducing them getting active disease, and it's even reducing them. If you reduce if a quarter of the vaccine of our kids who have BCG vaccine do not get infected, that means a quarter of our kids born in Kenya will not have latent TB. That's the bottom line. And if those a quarter of kids don't have latent TB, in 20, 30, 40 years, they will not be part of the pool who develop active TB and transmit. So if it's in the, looking at the long journey, it's a really BCG vaccine. It continues to be a powerful tool in this battle. Okay, so the next side of prevention is among kids who have been in contact with TB, let's find them and let's give them TB preventive therapy. Okay, I don't have time to go through all the issues of contact tracing, but to me, I think the most effective is whenever you diagnose an adult with smear-positive TB, empower that adult and tell them, Najua, like COVID, this disease can spread to your kids. Can you bring the children in your household? We test them, we assess them. We do a chest X-ray, do a MAN2 test. We assess them. And if they're fine, we give them some drugs to prevent them from getting this TB that's making you so sick. I think that's the most powerful thing we can do. And I really plead with all the clinicians and all the nurses, everybody in this forum, that have that, empower the parent. Once you empower a parent with that information, I'm telling you, they will bring those kids. Once they know that, we saw it with COVID. When somebody was sick with COVID and they were terrified for their kids, and they would bring their kids for testing. In fact, us as pediatricians, we were always getting calls, of terrified parents. Of course, kids were much less affected than parents, but now we have the flip situation with TB. TB is not like COVID. COVID was sparing the kids, but TB does not spare the kids. So let's do that. Tell parents to bring. We don't really have the resources. If we had enough community health workers to send them to every home of every adult who has TB, that would be great. And where we have those resources, let's go ahead and do it. But where we don't, just let the parents know. Bring the child, we assess. If they're fine, we give them TB preventive therapy. So do contact tracing, okay? Or have the parents bring their contacts. All right, so once they've brought their contacts and you've assessed them, and you find this child doesn't look, they don't have any symptoms, examine them, they look completely fine, they're growing well. I think this child, they are not yet sick with TB disease, then we can give them TB treatment. I'm going to go through some of the emerging data on new TB preventive therapy regimens that has come out over the last few years. This one is this came out in recent guidelines I just want to focus on another. This was a study of randomized. Sorry, this is a meta-analysis looking at several studies that were looking at different TB preventive therapy regimens. Now, of course, there's the standard. The placebo was just isoniazid, because our standard TB preventive regimen has always been isoniazid. In some countries, it's 6 months. In some situations, you give it extended. Okay, so in most of these studies, the placebo was isoniazid, right? And then the intervention was your here's our comparator in this column. You have your placebo, which either you don't give anything or you give isoniazid, and then this is the intervention. And here, then they showed in the two arms, you show whether the risk of developing incident TB was higher or lower. If this figure is less than 1.0, it means that your intervention was protective. Okay, so this is the data. So just to summarize what they found from these meta-analysis, they found that the following regimens were just as effective as giving INH once a day for 6 months. If you give rifampicin once a day for 3 to 4 months, this is a shorter. Rifampicin is you give a shorter course for 3 to 4 months, it was just as good. If you combine rifampicin and isoniazid and give once a day for 3 months, it was just as good. 3 months compared to 6 months is great. If you give rifampicin combined with isoniazid, and this regimen, you give it once a week for 12 weeks. So basically you give 12 doses over 3 months of rifampicin and isoniazid. It was just as good. 12 tablets spread over 12 weeks. This was really encouraging. And then looking at the safety, all of these new short course regimens had very low hepatotoxicity. So hepatotoxicity was rare. And actually 6 months of INH, 9 months of INH showed a bit more hepatotoxicity than the shorter course regimens. So they were safe. So based on that, now that was, those previous were trials that involved largely adults, or a mixture of adults and children. So here we have one RCT that just focused on kids. And they analyzed the pediatric cohort that was nested within the larger trial. And this was a big trial across 29 sites, North America, Canada, Latin America, a few European countries, and Hong Kong. No African country, unfortunately. And so they had about 1,000 kids aged 2 to 17 years who are IGRA positive, had latent TB infection. Okay, so they knew these guys have been exposed to bacilli, and the bacilli have infected them. Okay, but they're not sick, not active disease. And so they randomized these kids to either to H, and we call this rifampicin and isoniazid times 3 months, compared to just INH once a day. And they found that this 3-month regimen, once a week for 3 months, it worked in the kids. The TB incidence was low in both of the arms, just 0 cases in we call this HP arm, 0 cases, no cases of TB, and only 3 cases in isoniazid. So in kids, this regimen works, and adverse events were very low, less than 1%, okay, of hepatotoxicity. So based on some of that emerging data, the WHO now made a major policy change and said that we have enough evidence to. So currently, our preventive therapy, this is mainly for those kids who are HIV infected, who are on ARV drugs that might interact with rifampicin. With HIV, you still have a challenge because of rifampicin. It messes up your protease inhibitors. So with HIV population, we are still, especially kids, we are still stuck with the 6 months of INH. But for the rest, kids of 0 up to 15 years who are in high TB incidence countries, it is approved to give just your RH once a day for 3 months. Okay, RH is it's a nice, like, dispersible. It's like a sweet. Kids really love it. So it's a nice pediatric formulation, which all the young kids can eat. So for kids 0 to 15 years, if they're TB exposed, you can use this 3-month regimen. If they're older, I think this regimen is 10 years. An adult tablet, the tablet rifampicin, and isoniazid is a separate tablet. But its beauty of this is that you can give it once a week for 3 months. So just 12 doses for the children who are for the teenagers. So my friends, where we have children who are in contact with sick, just give them your, especially please pay attention to those who are vulnerable for whatever reason. And let me give you a few examples. Kids who have sickle cell disease. Sickle cell, remember, you have your repeated chest sickling, and you can get their lungs develop chronic lungs. So sickle cell disease. Kids who have cardiac disease, renal disease, nephrotic syndrome on steroid therapy. Those are all immune suppressed patients. People who have other renal diseases, rheumatic conditions on steroid therapy, kids with malignancies. All these kids are vulnerable. Their immune system is not so strong, and they're vulnerable for getting active disease. So if you're going to assess and say, okay, this 8-year-old, this 11-year-old, should I give TPT? Any child who has an underlying comorbidity, please lean on the side of giving them the benefit of this TB preventive therapy if they've been in contact with an adult who has TB disease. Okay, and the doses are the same as for treatment. Okay, for isoniazid, so RH, you just use the same dosing table as we're using for TB treatment. Okay, and in Kenya, the beauty is we have dosage tables that tell you for the pediatric tablet, if it's, you just look at the weight of the child here, and then you know the number of tablets. If they're the older kid, like above 10 years, they can swallow tablets. Yeah, just use the adult tablet. HP, you have your isoniazid dose and your rifampicin. Rifampicin tablets, they actually have a nice small 150 milligram tablet. 150 milligrams not very big, so even a 6-7-year-old might be able to swallow this. So, but in Kenya, we've only approved to give it for the teenagers. So rifampicin, the doses are there. Okay, so now let's switch gears, and we are going to now talk about diagnosis. So maybe we failed. We traced the child, or we've just, this kid has been out there in the community. They've picked up TB and they're sick. So they are presenting to us sick with TB disease. Now, making the diagnosis. Actually, this has been our biggest battlefront for children across the world. Challenges in making the diagnosis. So I'm just going to try my best to help make it simple. I hate that word, that making a diagnosis is a challenge. I really hate that kind of language, because once people use that language, the health workers just say, ningumu, uyu tuma Kenyatta, tuma Moi teaching, tuma, send to the pediatrician, and then or send to the pulmonologist. So I want to demystify diagnosis. Our biggest challenge is often we just say, this is pneumonia, because maybe they're breathing fast, they're coughing, they have fever. For those who come with wasting, as you could see, 1/3 of these kids present with what looks like severe acute malnutrition. We just call it malnutrition. We give them RUT, we give them food supplements. So we misdiagnose them. Remember, TB in kids mimics some of these conditions. It mimics pneumonia, it mimics malnutrition. Eventually, when we do make the diagnosis, several weeks to months down the line, we say, hey, pneumonia is not responding, or this malnutrition, I'm giving all the nutrition, is not responding. We make the diagnosis, we make it when the child has now progressed to advanced disease. And as a result, they often come in, especially the kids under 10 years. Let me say under 10 years, not even just under 5. They come in with really severe protracted disease. And often if it's TBM, it causes brain damage. If it's lungs, it causes damaged lungs. So I'm going to attempt in the next few months to go back to the basics, okay? To help us, we just have to begin, we have to go back and understand the pathophysiology of primary TB in children. So the child inhales, okay? This bacillus, it moves, it's inhaled, you know, in air, and it moves to the, usually it will move to some alveolus towards the periphery of the lung, okay? And settle there. Now this is the TB bacillus. The TB bacillus is then engulfed by macrophages. Macrophage pours out all sorts of enzymes, tries to kill this bug, it doesn't succeed. So, but it contains them. So here, eventually you have lots of macrophages, which are carrying TB bacilli. Now the immune system responds because all sorts of signals have gone out to the innate immune system as well as to the whatever, the humoral immune system. And so lymphocytes are mobilized, T lymphocytes, B lymphocytes are mobilized to try and start helping the macrophages to destroy. And so eventually you form what we call a granuloma. Okay, in the center of this granuloma, you have the TB bacilli sort of being held hostage, surrounded by all your lymphocytes, your monocytes, etc. If this granuloma doesn't win the war, you get liquefaction, and eventually you have release beyond the granuloma of bacilli, and then they spread to other parts of the lung. Okay, so just here showing, I'm trying to use these pictures to help you to see exactly what's going on. So this child inhaled this bacilli, it settled in an alveolus, formed a granuloma. The lymphocytes and the macrophages containing these TB bacilli, they're transported via the lymphatics to the regional, the hilar lymph nodes. And the hilar lymph nodes continue to be the central sort of army, what do you call it? War ground, trying to destroy these. So the lymph node, so you have lots of bacilli in here. The lymph nodes are more and more immune cells are migrating here, inflammation, and the lymph nodes increase in size. So this is what primary TB looks like in children. So you have your primary granuloma, or a few of them, and you have your lymph nodes enlarging, okay? So that's what primary TB looks like. Now, at this point, there's an infection cooking in there. It's probably several weeks into the illness. And the first symptoms will be, the first symptoms at this point are non-specific. Then child will be having a bit of fever, but not a high grade fever. They stop putting on weight well, okay? And they're just feeling unwell. They are lethargic. In an adult, you'd say, I'm always tired. But a kid, mom will notice this child is not running out to play with his friends as much. He seems to want to sleep on the bench, or he plays for 5 minutes and seems to get tired quickly and just sits down, right? If it's a young baby who's not yet walking, the lethargy is manifest as often they might actually regress in their milestones, okay? And they're there. So these are the initial symptoms. I really want you to keep your eye on this, keep your eye on the gold, okay? These are the classic 3: low-grade fever, poor weight gain, and lethargy. There's evidence, enough papers that show you that these are the 3 sort of, I call them cardinal symptoms, and they tend to linger on for more than 2 weeks. And if you take a careful history, you will get this, okay? Initially, at this stage, the child is not coughing. They actually have no respiratory signs, but the TB is cooking. Okay, now, the child doesn't get to treatment, so the nodes continue to get larger, And what happens? You can see these nodes are pressing on the airway. So you start to get compression, obstruction of the airway as the nodes continue fighting the battle to clear this TB. So you get airway compression, okay? It's still just in the lymph nodes. You can see there's not much, you don't see pathology in the lung parenchyma. And what symptoms will you have at this point? You have the cardinal. It's now now you're going to 6 weeks, maybe even 3, 4, 5 weeks. You're having your fever. They're not gaining weight. They're always looking tired. Okay, it's been going on for weeks, and now you begin to, because it's blocked, they start to breathe a bit fast. Actually, I'm amazed as I take careful history and examine how often this is the initial. So take a respiratory rate, and you'll find that they are breathing faster than usual, but they're not coughing. And at this point now, you begin to hear the turbulence of the air going through this narrowed airway. So you begin to hear wheezing. Okay. And one of the cardinal signs is often lymph nodes are causing, there's more pathology often on the right side of the lung, because for some reason the first TB bacilli tend to settle on the right lung tissue. So often you'll find it's asymmetric. So one side you're hearing wheezing, and the other side, hakuna. Or if it's bilateral, the wheezing is louder on one side compared, there's asymmetry. Again, to me, this has been, over the many years in which I've seen many kids, this has been one real red flag, that this wheezing is TB. It's not asthma. Okay, so asymmetric. And the nature of the wheezing, it's more low pitched. It's a large airway. So rather than hearing the musical wheeze of asthma, the musical wheeze of asthma is sort of at the end of expiration. You will hear it's air through a larger pipe. So it seems to be of a lower pitch. And it's pan-expiratory, classical sign. Okay, and at this point now, you'll have secretions accumulating. Because the airway is blocked, secretions start to accumulate and the child now starts to cough. This may be 5 weeks into the illness, okay? They start to cough. But if you take a careful history, you'll find moms like, huyu amekuwa na joto off and on for the last 1 month. Na siku hizi hana nguvu, hachezangi, she likes to just sleep, and for the last like 3 weeks. And then the cough, she'll tell you, has only been for 5 days. And the child comes in because he's coughing. And this is where it has appeared to us that some kids present as if their TB presents as if it's an acute pneumonia. Because the only thing that really now began to make mom feel that, hey, mtoto ana kohoa, kohoa is equal to pneumonia. They bring the child in. But if you take, it looks to us like it's an acute cough, but actually there are other symptoms that have been lingering on. Okay, as things get worse, now at this point, I want to start talking about the investigations, because if we understand this pathophysiology, we will now begin to look at the investigations. Which investigations will be revealing? Remember, the TB bacilli are hidden in the lymph nodes. They're not in the lung parenchyma. Very little in the lung. If you take sputum is coming from alveoli, okay? And remember, the bacilli are largely just hidden in the lymph nodes. So we take sputum, we do all our efforts to do maybe gene expert. It will be negative at this point. There's no parenchymal disease. It is negative. Primary TB in kids, when it's at this stage, the bacilli are not in the sputum. Okay, so it's negative most of the time. Gastric aspirate, basically you expect a child is coughing up the sputum and swallowing it. These younger kids, they don't know how to remove the sputum. So they're coughing, swallowing. So the mucus is accumulating in the stomach. And that's the rationale for us taking gastric aspirate and trying to now get from the mucus that's in the stomach, we try and look for the bacilli. The gastric aspirate is also negative. And I'm sure for you, for those of you who have been working in the field and you've sent all sorts of gastric pediatric samples for testing, you find that many of them, that it looks like TB. History suggests TB, exams suggest TB, but sputum is negative. That's because it has not yet spread into the lung parenchyma. Okay. At this point, one test that will show you the pathology is a chest X-ray. Okay, so this is I'll do a lot of chest x-rays later, but you can see in this chest x-ray, normally you have your nice lung full of air. It's supposed to be black with maybe just very small sort of lines showing the lung interstitial markings, okay? But you're not supposed to see this opacification in this area. So this is the trachea. It breaks into the right and left bronchus, and this would be around the hilum area. And you can see there's some sort of opacification, and the shape of this opacification, this is a soft tissue kind of, is it a soft tissue? Is it airways disease? Because of the shape, this is classic hilar lymphadenopathy, and this is what they look like on an AP. And in children, because it's sometimes difficult, if the child hadn't taken a good inspiration like this, here they've taken a really nice inspiration. So you can see the heart is sort of long and narrow, and then you can see the hilum well. But many x-rays, the kids, the x-ray, a 4-year-old, you not tell them, Aya, what happens? Hold your breath. Hold on. Many kids at this time, they're crying, they're wiggling all over the place. So sometimes it's difficult to get a good inspiratory film. So this might be hidden behind the heart. So we usually recommend for younger children, if we think it's primary TB, to do a lateral chest x-ray. And this is the sign that you will look for on the lateral chest x-ray. This is what we call a donut. You see a ring of opacification. Now, let's just orientate ourselves. This is the front of the chest, that's the sternum. This is the heart. This is the spine. And here you have your, it's a bit cut off, but you have your trachea somewhere here, okay? At the bottom of the trachea, it divides. And you might have, now normally, especially here below the carina, you should not see opacifications. When you see opacifications below where the trachea ends, that is usually due to a soft tissue mass like a lymph node. And if you see the opacifications behind the trachea, okay, then that is most likely due to lymph nodes. The opacifications in front may be the aorta, etc. But when you see this is called the donut sign. They call it the donut sign. The donut sign. If you see that ring of opacification, that is a hilar lymphadenopathy. And now put that together with the clinical symptoms. I always tell students that don't just make your diagnosis from the x-ray alone, put it together with your clinical symptoms. So if child has been having fever, poor weight gain, lethargy, they're beginning to cough recently, or they're wheezing, your examination, they're wheezing, and then you see the chest x-ray like this, your clinical diagnosis is primary TB. That's your most likely diagnosis. Now, by this time, what other tests can you do? Mantoux test. Mantoux test is a cell-mediated immune response, which normally takes about up to 6 weeks. It takes usually up to about 3 months for it to be positive after the initial infection. Yeah. So if it is more than 3 months from the time the child has got an infection, the Mantoux will have turned positive. It can turn a bit earlier, but 3 months is when you get the peak CMIs kicking in. So you can use your chest x-ray at this point. Now, as the lymph nodes get even bigger and they're compressing the airways, these are just nice examples where you can see the effect. This is the trachea. This is the left bronchus. This is the heart. And you can see some hazy opacified tissue surrounding that bronchus. And this bronchus is really narrow. It's being compressed by these large lymph nodes. And the other effect, and it's a very it's a subtle sign that you should look for. Look at the size of this. This lung is very, very black. There's air trapping. And this is because you're having a ball valve effect. Air is getting in, and as the child breathes out, it's being blocked because of the airway narrowing. And so you have air trapping, and that lung looks very black compared to the other. It's not that this is the normal and this is the abnormal. This is actually the abnormal lung. Very, very hyperlucent, okay? Because it's really trapped with air. So this is primary TB in children. And you can see the mediastinum is even shift because there's severe obstruction of that left bronchus. Even the other bronchus is narrow, but not as badly so. And the similar picture here. Now in this particular child, the trachea is being compressed by paratracheal nodes. That airway, that bronchus is really narrow, so there are huge nodes around it. This bronchus is extremely narrow. You have probably lymph nodes compressing it. And you can't really see the margin of the heart, but what I want us to appreciate here is that you have opacification in the upper lobe. This is what we might call expansile pneumonia. TB may have settled with many little granuloma in this lobe, and they have spread to involve, it expanded. The TB infection spreads through local tissue, and we call it an expansile pneumonia. And it's another strange way that TB behaves in children. Now, at this point, your child is having your cardinal signs. They're having the fever, the poor weight gain, and the lethargy. And now you'll have obvious respiratory signs. Here, they're coughing a lot. They may be wheezing, or you hear rhonchi. They're breathing very fast. Their respiratory rate has really gone up, and they're now really losing weight, okay? So they're trying to remove trapped sputum. So here now you have your classic cough, which is lasting. And here I've just thrown in one more X-ray to show the infection may spread, and you may get the TB, the lymph node eroding into a bronchus and discharging all its infected material. And the infected material then cascades down the airways to infect the whole, either segment of that's served by that bronchus. And lo and behold, with this particular kind of spread, then you will see a whole segment. This is mainly the middle lobe, right? Middle lobe is consolidated. And you can see the very narrow airway. You can see the hilar lymph nodes and narrow airway, air trapping, hyperlucent. But here, the main thing is you have middle lobe consolidation. And when you listen here, you'll hear your bronchial breathing, okay? It'll be a bit dull here compared to other sides, okay? And then you have a hyperinflated lung because of air trapping. So this is another way you can have a lobar segmental. Now, by this time, there's enough TB in the airspace. And at this point, okay, your chest X-rays are normal, your mantle is positive, but now when you take sputum, if you really work hard, you may get a positive expert, or you may get a positive TB culture. But the challenge with these young kids is even when you get this, it just takes a few bacilli to make a child very sick. These kids under 2 years, they have Possi bacillary disease. They have few bacilli there, but even those few bacilli, they get very, very sick. And so you might have a child who looks so sick and you say, gosh, how come the sputum is not positive? It's because possibly it's below the limit of detection of that either microscopy test or below. You need a high number of bacilli per cc per mil of sputum for it to reach a detectable level. And then the worst situation now is that your TB, your nodes erode into blood vessels and discharge the TB bacilli into blood vessels, and you get hematogenous spread. And it spreads through all the capillaries of the lung. It spreads through the whole body, and you get disseminated TB. In the lungs, we will call this miliary TB. In the brain, it will be TB meningitis. It'll affect the abdomen, etc. So you'll see the little millet seeds. So your chest X-ray will pick it up, okay? And by this time, of course, this kid is really sick. They are having severe symptoms. They're having fever, which is now becoming quite high. They're losing a lot of weight. They are really lethargic. If they are young, under 1 year, they are regression of milestones, okay? Lethargy is equal to regressive. So those three cardinal signs, plus they're coughing, and when you have disseminated TB, you probably are, these are the kids, actually from my experience, where you're more likely to find the TB bacilli or antigen in urine if you do a LAM test. You're more likely to find the TB if you do a deep sputum induction. It's more likely to be positive. Your gastric aspirate is more likely to be positive. So disseminated TB, you've really missed the boat. And I wanted to show this one because I've seen several cases where people see this and say, this just looks like a typical bronchopneumonia. What is happening here is that every little granuloma, you have local spread to the surrounding tissue. So what was initially a little millet seed spreads to the surrounding tissue, and it looks like cotton wool now, the patchy opacifications. And you can see in the left upper lobe here, there's more diffuse opacification. So this infection, the granulomas have spread to surrounding tissue until they're involving the whole left upper lobe. And so with progression, TB can actually on X-ray look like bronchopneumonia, okay? Or even like global consolidation, as you can see here. Here, of course, now, if you investigate, you should not miss this chest X-ray. If you do, I would be very unhappy with you. Your MANTU is higher, because this is several weeks into the illness, and so by now your CMI has kicked in, your cell-mediated immunity has kicked in, and your MANTU is strongly positive if they're not immune suppressed. Sorry, but by the time you get severe disseminated TB, it itself becomes an immunosuppressive condition. I think what happens is that you have overwhelmed the immune system in fighting these bacilli, and you eventually get depletion of lymphocytes. And so you overall then get into a state of immune suppression. So with this kind of TB, your MANTU may or may not be positive, because now the lymphocytes are all depleted and then no longer they're exhausted and unable to mount that response to the tuberculin reagent. And here again, your bacteriologic tests are much more likely to be positive. Okay, so I think I've taken you the journey. I really tried to take us back to understanding the pathophysiology so that you can link it to understand the early stages, how TB will present, and as it progresses, only when it's really advanced is when you're going to have the classic coughing, a lot of weight loss, persistent fever. But in the early stages, you have to have that high index of suspicion. And it's really helpful to go back and try and find if there's history of contact, right? So how do we make the diagnosis? For TB in kids, it's the same as with most child diseases. Take your history. It's simple. Take your history, examine the child, okay? From your history, do the symptoms look like TB? And I've mentioned the 4 sort of cardinal symptoms. Okay, in your history, really try and look for that positive contact. And in our setting, because we are a high TB endemic country, that positive contact may not necessarily, you ask in the home. In the home, you have to go ask a little bit further and say, is it not just somebody currently in the home coughing, but maybe it was an uncle who came to visit, or a grandparent who came to visit, or it was a maid who was coughing, and nobody knew she had TB. So ask, in the last 6 to 12 months, has there been anybody who has been in contact with this child who has been coughing a lot, or whom you know has a diagnosis of TB? Okay, sometimes kids are taken to daycare, especially in the settlements, and sometimes they're taken to a daycare, and maybe the person handling that daycare is the mama handling the daycare is the one who's sick with TB. So you have to ask a little bit deeper. If it's a teenager who's going to school or is in a dormitory, they could have been exposed in the dormitory. For the young kids, from your history, if they've been repeatedly, for whatever reason, they've been a sickly child, they've been going to hospital, or maybe they were admitted into the ward a few months ago. In that ward, in the bed next door, there was a caregiver who was coughing with TB. So your positive contact could be in the home, it could be in their school, in the dormitory, it could be a neighbor, or it could be a previous hospital admission, or sitting in casualty waiting to be treated, and you're sitting next to somebody who's coughing with TB. So really, the positive contact history, again, I've found time and again, when students are presented to me, they say, hakuna history of contact, and then I'll turn and ask the mom, the last time you admitted, was there somebody in that room who was coughing? She said, yeah, but the person next door, the mama was coughing, and she was very thin, and she was looking very sick. Or she'll say, I ask her, do you take this child to be cared by anybody? She said, yeah, I usually take to a daycare. Actually, who your mama na Cohort? So it's really sensitized me to looking deeper when I'm having positive contact history, because this child got that TB from somewhere. So take your history, especially history of contact, and ask for these symptoms. You have to specifically ask for them. Otherwise, mom will only remember to tell you, she's been coughing for the last 5 days and now she has high fever. And then do your examination. An examination, any abnormal exam, the first earliest sign is increased respiratory rate. So take the respiratory rate and interpret it. Any abnormal exam, chest finding, okay? And then take your temperature. And often it's just a low-grade temperature. Remember, the gun is very inaccurate. A normal temperature with the temperature gun is 36.6. I'm sure you've had your temperature done in all supermarkets. So if it's a temperature gun and you've taken the temperature and it's showing that it's 37.2. For a temperature gun, that is fever, okay? If you were to put a rectal temperature for the same child, you would add 0.6 degrees. It would be the 37.8. So remember, use an accurate measure of fever, and then of course assess your. So just do it like any other disease. You take your history, you examine the child, okay, and then you make your clinical diagnosis. And as I said, for household contact, you sometimes the person who brought the TB was with the family many times before. If there's no other slide you remember from this lecture, I really would hope that you can remember this slide. Okay, so this is, we have tried to make a very simple approach from your history, pick out the gold nuggets, from your examination, pick out the gold nuggets, and to help you make a clinical diagnosis of TB. All right, so here you can, presence of 2 or more. If the child has 2 or more of these symptoms, cough, they have the 4 cardinal symptoms. They have 2 or more of these 4 cardinal symptoms, plus they have positive contact history, or you examine any kind of abnormal respiratory sign. You do a chest X-ray, it looks abnormal, or if you're able to do a Mantoux test and it's positive. Any 2 of these are positive, 2 + 2 or more, then you can make a clinical diagnosis of pulmonary TB in this child, and you are justified in starting treatment based on high index of suspicion based on this. Okay, so you can see just by doing history and physical examination, you might be able to make your clinical diagnosis, because sometimes you will not, you're working in a place where there's no chest X-ray nearby. Mom cannot afford the transport to go to that hospital, which has she can't even afford the chest X-ray. Mantoux is just not available, okay? Let alone getting a sputum induction done, it's not available. So you might be working in a setting, and most of these kids are in the community, living in rural, in rural settings where they don't have quick access to some of the investigations. So if you're in that setting where you can't quickly really get your chest X-ray, your Mantoux, you do a sputum, etc., you can be able to make a treatment decision by history and examination, high index of suspicion. If you're really not sure, you can give your 1-week trial of antibiotics. Give your 1 week of, if they're very sick in the ward, you give your 5 days of injectable antibiotics. If they don't get better, now say, okay, this I thought was pneumonia, but it's not responding to my crystalline penicillin or my amoxil, is oral amoxil. See the child 1 week later, if it's an outpatient, they're not getting better, then that helps you to make your diagnosis. Failure, pneumonia, which is not getting better, with antibiotic therapy. I've just thrown in this slide so that you can remember that, like I think in 15% of kids, the TB is both pulmonary and extrapulmonary. In older kids, the TB may just be these huge lymph nodes, cervical lymph nodes. That's the most common form of extrapulmonary TB. So you can use the same simplified clinical approach to diagnosis using this, okay? Where instead of it's cough or wheeze, you put the symptom arising from where the disease is, okay? And your examination, you examine it's either enlarged lymph nodes. If it's meningitis, they have a stiff neck, positive KNH, etc., and take the sample relevant to their organ, okay? Okay, so I'm just putting this in to show you that in 2014 WHO guidelines, we just emphasize the same, yeah? Just do a history examination, do tuberculosis, you do a Mantoux test. If you can do a chest X-ray, please do it. Try and do a bacteriologic confirmation, but renotice the sequence and investigate where you can, all right? So we must arm ourselves with good understanding of how to analyze. I want to now spend a little bit of time looking into TB tests. Wow, time has really gone. I think I may not be able to go as far as I wanted, but what I wanted to show here is that from Dr. Jacqueline Oliva's extensive research on this subject, she looked at our national TB situation of how do we make the diagnosis of TB in kids, and she found that majority of them, we made a clinical diagnosis, okay? Just on history and exam and maybe contact. Only 11% got X-rays, and only 1% of Kenyan kids in 2018 got at least one bacteriologic test, and only 1.6% of kids got both chest X-ray and expert. So we are making clinical diagnosis in majority of kids, and this tells you the real picture of access of kids to these bacteriologic tests, okay? And you can see here, this was from the NTP boss a slide that he had presented at some point, and you can see in kids, pink is the bacteriologic, those who are bacteriologically confirmed, either they were expert positive or microscopy positive. And you can see that only 15% of all the kids who get TB are we really able to make a bacteriologic confirmation in Kenya. This is Kenya data. 85% we are making a clinical diagnosis. So if you're afraid of making a clinical diagnosis, please don't be afraid, because you are. If you can't get, you might be able to do the test, but it comes back negative. It's okay. If it looks like TB, it sounds like TB, it smells like TB, just make a decision to treat that child, okay? You can see that the most available test across Kenya is sputum microscopy, okay? And still in the remote areas, even that is not widely available. Expert, we have really worked hard, but it's not available everywhere. Even in Kenyatta Hospital, we have been having stockouts of even the reagents. So maybe this reads into why most of the kids don't actually get the test done, because it's not accessible. Most of the kids are, remember, out there in the community, many in the rural areas, living far away from, yeah. And now I just wanted to look at data that helps us to understand how we can interpret an expert report. This is a South African study, and in this South African study, they compared, these were kids who were hospitalized with suspected clinical diagnosis of TB, okay? And so in some of these kids, their sputums were sent for expert, and then others were, so they took samples from all these kids, and for each child, they sent a sample for expert, they sent for ultra, expert ultra, and for culture. And then they compared these three to see which was picking up the most TB, okay? And these were generally kids under 5 years. Now, they found culture was positive in 19%. So only 19% of all the kids we were able to do get a positive TB culture, but clinically they had a clinical diagnosis of TB. Expert was positive in only 15%. Expert ultra, which we thought was, wow, this one is going to, it has a much lower limit of detection. I think it detects below 15, up to 15 bacilli per cc of sputum. So we thought this one, because it detects paucibacillary, should help us, but it was really disappointing that it only improved on expert, the standard expert, by 2%. So even these kids really have paucibacillary disease, and perhaps many of them, the TB was just in the lymph nodes and not yet in the sputum. So you can see this was a very revealing study, that even when you send a sample for expert, please remember this slide, that of all the 100 samples you send for kids, especially the younger kids under 5 years, like these ones, only 15% of them with that expert reveal the TB. But it doesn't mean that the 85% do not have TB. And if it looks like TB, it sounds like TB, you have a high index of suspicion, maybe you've given you a few days of amoxil and they're not getting better, just make your decision and give that child the benefit of treatment. Okay, now I think I want to find out from the organizers, because I think I still have a few slides to go. How much should I wind up here, or can we give it a few more minutes?
I think we can take a few more minutes, Prof. It's all right. Okay,
thank you, Tania. Right, so here I want to encourage you to, this is a recent review article which looks at the point of care, the newest point of care tests for TB in children, and what evidence is out there. As you can see, we still are struggling. We want to be able to make a bacteriologic confirmation if we can, but our current tests so far are really useless, only 15% sensitivity. Okay, so what's new? Okay, this review, they capture the current state of the art for point of care TB diagnostics, and I think you can see there's a really nice summary table. Bottom line, the only one that seems to really work well and is child friendly is the LAM. Okay, this is a urine dipstick test. Beautiful. You just put urine on the, just like doing a urine, like a glucose. You take a few drops of urine, put it on the dipstick, and at the bedside, if it turns the right color, then you know it is positive. Now, this alarm is useful in the kid who has very advanced disease. Okay, HIV positive patient who has low CD, who's very immune suppressed, you have a much higher detection rate. And the child who has disseminated miliary TB, where TB are all over in the blood, and therefore the TB antigens may be spilling in the urine. That is where this has a higher detection rate, but it's still low, only 40 to 60%, okay? But when you detect it positive, it's very specific. So it helps give you confidence. Child-friendly because it's a urine sample. All these others are not child-friendly, and they're user-friendly, the LAMP, but it's not widely available. Expert Omni is coming through, but it needs, we hope that this will be rolled out soon, but the problem is you need sputum. So for the young child, it still remains a problem. And the TrueNat, again, you basically, it can be used at lower health facilities. It's a battery operated thing, it doesn't need electricity, but its detection rate is really low and it's really not been tested. Where it's ND, it's not been tested in children. So we don't really have much. We don't really have much. Chest imaging is still one of our better investigations. Okay, so here, sorry, this is another review article. It's all in the same sort of journal, Pathogens, where we looked at all things TB for children. So again, I would encourage you to download this. It's a nice update on what's new in terms of using chest imaging to make a diagnosis of TB in children. Okay, so here, I think this, I've talked about the donut sign, that's a typical chest x-ray, but CT scan, where you're not sure about your lymph nodes, the CT scan of the chest may be very helpful if you have access to it, okay? And what will it look like? You can see this is the x-ray, and this is the CT scan of the same child. And here you can see, look at that, bronchus, it's really narrowed by lymph nodes. Look at that, that's a huge lymph node on the right. Okay, so if you look at, they took a CT, this CT was cut around here, okay, where you had divided into the right and left bronchus. And so it's an axial cut, and you can see, sorry, no, this is the trachea. I think they cut this over here. They cut this over here because this is the trachea. So they cut this, this is a cut around here. And from here, you can see this mass here is that mass, okay? And then you have another mass on the other side is that mass, paratracheal lymph nodes. And the trachea is here. So the lymph nodes are sort of hypodense opacifications with a rim of white, okay? A rim of accentuation. That is a typical lymph node and a lymph node there. And you can see that the trachea, which should be round in shape, is being compressed anteriorly. So a CT scan is helpful in picking up lymph nodes disease if you're really not sure. Okay, now this is another patient where this is the x-ray of the child, primary TB, typical. I hope you'll really be picking up these x-rays because you can make the diagnosis. They have this narrowing, they have a few miliary dots here, okay, and they have hyperinflation. It's very black here because of air trapping, very black here, okay. So if you look at the chest CT scan of the same child, if you look at the coronal view, now it's beautiful. You can see the trachea, the right bronchus. It gives up the upper lobe bronchus. This is the bronchus intermedius, and you can see it is really narrowed. Exactly what you're seeing at the arrow there. You can see it's narrowed by external soft tissue mass that is compressing it. So that's a lymph node, a hilar, perihilar lymph node. Again, here's another perihilar lymph node. Here's a subcarinal lymph node, hypodense mass, okay? And here's a subcarinal and here's another lymph node, and they are both compressing the left bronchus, okay? And the axial cut also shows you that here you have the bronchus on the left and the bronchus intermedius on the right is completely compressed. What you saw here is completely compressed, and this is a mass of lymph nodes. This is the pulmonary artery dividing into the two. And so just to orientate yourself. So chest X-ray, chest CT scan may be useful. And finally, chest ultrasound is the new kid on the block. And chest ultrasound in kids, because the size of the chest of the kid is so small, ultrasound is increasingly becoming used in imaging for kids with lung disease, chest ultrasound, but there's a learning curve. The beauty of it is no radiation. It's a bedside thing. You get your picture immediately. Now here's a child. You can see this white out here, and you can see this rim of opacification. This child, look at the costophrenic angle, and you can see this meniscus. So this child has pleural effusion. They also have extensive opacification. So they have lung airspace involvement, consolidation from either the TB or maybe also a superimposed bacterial pneumonia. So if you look at that pleural effusion, if you put your ultrasound machine here, over here, right in between at the level of the liver-lung interface, this is what you will see. You will see the liver is a nice consolidation. This is the red the sort of hepatization picture. That's classic liver on ultrasound. This is lung, where you can see these rays. And this black area here is effusion. Remember, fluid is hypo, it doesn't, the sound waves do not echo in fluid, so it's just black. And that you very quickly make a confirmation that this child has pleural effusion. It's not a massive pleural effusion, so it may not easily be picked up. You would easily miss this on the X-ray. And it's not enough for you to really safely do a pleural tap, because your needle, the size of the effusion not, but your ultrasound will pick it up. So ultrasound is useful. Okay, I have to throw in this one to show you that where these kids, we might diagnose them late and treat them and they survive, but some of them actually survive with damaged lungs, scars in their lung. And this is a child we had in Kenyatta a few months ago. He was HIV infected, but also came in after many months of treatment. He was from the coast. So he had gone from a small sub-county hospital, eventually to the county hospital, eventually to Coast General. Eventually they sent them to us, and this is what he had. And he was on, I think, his third course of TB treatment. And this child, this is his lung. Look at the CT scan. You have big holes in his lung. He had the most severe bronchiectasis that I've ever seen. This is what we call cystic bronchiectasis. And he had a lot of lung fibrosis. So we healed the TB, it cleared, but this child was oxygen dependent. So TB, when we diagnose it late, when we dilly-dally to make a decision, saying, oh, we are waiting for this test, or we're sending him for X-ray, or we can't do a sputum induction, or when we dilly-dally and allow it to progress throughout, this is the end story. And this child needed a lung transplant, which of course we can't provide. We sent him home for palliative on home oxygen, and he died surrounded by his loved ones a few months later, somewhere deep in Kilifi from an extremely poor family. So I think let's always remember that. So let's be able to use history and examination to make your decision. If you can attempt, we can attempt MTB detection, but remember, in most kids under 10 years, it's actually a bonus, okay? And don't be fixated on bacteriologic confirmation. Children are not small adults. In adults, yes, we say, let's get a confirmation before we treat. But in children, we cannot afford to be fixated on getting a confirmation before we make a decision. Being fixated on that delays treatment decisions with these terrible consequences for the child, okay? Now, I want to introduce my last slides. What's new? WHO yesterday released the new guidelines, okay? We have the last guidelines were 2014, so it's been many years. So WHO renews the new guidelines, and the major thing I want to highlight is the short course TB regimens. The new guidelines, by the way, they took all these books and merged all the information together, and we have a beautiful, these are the different modules. So they're published as different modules. Okay, module 1 up to, I don't know what module, but anyway, we have our module for children. So it's now available, and and this is the reference. So you can look at what's new in the management of TB in children and adolescents, and there's a nice operational handbook. Okay, so what's new is, one, we don't have to treat TB for 6 months. We can treat it for 4 months, okay? If it's non-severe TB, what is non-severe TB? That child who is not having life-threatening disease. Let me just summarize it that way. They're not in severe respiratory distress, or they have maybe lymph nodes only. They're not having a life-threatening disease. You can treat for 4 months. And what drugs will you use? You're going to use 2 RHZE. So you do your typical 2 months of intensive phase. The E means for high endemic settings. So for Kenya, we're going to stick to our 2 months of 4 drugs. And then instead of 4 months of continuation phase, we can now do 2 months of continuation phase where we only use 2 drugs. This is going to, and there's enough evidence that has shown 4 months of this treatment actually cures most of the kids who have non-severe forms of TB. So you can implement this. The next major change is for older kids, you can use with drug susceptible pulmonary TB, instead of rifampicin, you can use rifapentine, isoniazid, moxifloxacin, and pyrazinamide, and you can give it for only 4 months. So there are 2 regimens, but I think in our setting, this is expensive. Rifapentine is quite expensive. Moxifloxacin, we don't like it for kids. It messes up their tendons. You give a teenager this 4 months, they are going to have ruptured tendons. They're going to have all problems with sports. So personally, I don't favor quinolones unless you're having maybe for some reason. So I favor the previous regimen, but that's the good news. Now, for kids who have more severe forms like TB meningitis, the previous recommendation was 12 months of treatment. What's new is you can give a 6-month course of treatment. But for those 6 months, you must give the 4 drugs: HRZE, rifampicin, isoniazid, pyrazinamide, and ethambutol instead of 12 months. Okay, and but of course, because of all the adverse effects, you must monitor them closely. But 12 months of taking drugs is a long time, so this is great. Kids with TBM, you can give 6 months, but give you hit hard for the full 6 months. Okay, and then the final major statement is WHO. I think this one we know is encouraging that because most of the kids are out there in the community, they may not be able to come to the big city or to the big hospital. Decentralized, we should try and decentralize TB care and give it where they are. Give it in the MCH, okay? Give it in the pediatric wards. Where possible, try and make it accessible where the children are getting treated, not that they have to go to the TB clinic only. Okay, so, but it has to be done carefully to make sure that we do it well. Yeah, so I think I will end there by saying if we really work together, guys, we can plug all these gaps and we can win the battle against TB in children and adolescents. Yeah, thank you. I really am calling all of us to action. It's really time to win the battle and to end TB in children and adolescents. Thank you.
Thank you very much, Prof. That was definitely a tough topic to summarize and give the pertinent points in such a brief but still comprehensible manner. And given that we have such little time, I've just selected 2 questions that probably would be good to answer in the interest of time. The first question I'd like to ask on behalf of the attendees is, how long after exposure can you start the prophylactic treatment? The children have been screened, they're negative, and the adult had been on treatment for 3 months and above. After how long can you no longer give the IPT?
That's a very interesting question. Actually, I don't think anybody has put a hard and fast rule to that. So it's a very interesting question. But going by if I go by the pathophysiology, the natural history of TB in kids, in kids under 1 year, 50% of them will be sick within the next 12 months. Okay, so
yes,
under 1 year, in the next 12 months, even if it's 12 months down the line, give that prophylaxis. For the older kids, it's a smaller percentage of them progress. But based on that initial observation, I think you would expect progression within the first 12 months of exposure. And so even if the exposure was 12 months ago, assess that child. And the younger they are, the higher their risk, and therefore, especially the under 5s, still give it. If it's more than 12 years, perhaps now I think it's an area for research.
Excellent. Thank you. There's another question about neonates and tuberculosis. So what would be the best way to rule out tuberculosis in a neonate with a mom who is bacteriologically confirmed to have TB, given that we can't use MAN2 tests in the neonates and things like IGRA are not readily available?
With a neonate and mom is sick and the mom is with this baby 24/7, do you think you're going to remember neonates?
Yes.
Any kind of illness is equal to this child has sepsis or TB. Yeah. So almost 100% of them will be sick. They'll be infected. That baby is already infected. The chance of progression is very high. So from your assessment, remember, it's not bacteriologic. This is a clinical decision. With neonates, to me, it's a clinical decision. That child is showing any sign of not doing well. They'll have fever, they have hepatosplenomegaly, they are not putting on weight. You just make a clinical that, because if you have a very clear contact and it's a close contact, that child, that baby is infected. Yeah. If they're sick, then you're going to give them full TB treatment. If they look very well and strong, maybe it's still early, they look very well and fine, you're going to give your prophylaxis.
Okay. Thank you very, very much, Prof. There are so many questions, but I think we're well beyond the time that we have. But
sorry about that.
No, it's okay. I think a lot of the questions were asked a bit earlier, and you tend to cover it after as you progressed in the presentation. And honestly, it was quite illuminating. It was good revision, but thank you. So I would like to echo Prof's call. We have to end TB. We've lost a lot of ground due to the time that we were having the COVID and people weren't coming to hospital as much. So keep your eyes open. Like she said, if it sounds like TB, looks like TB, smells like TB, just treat it. So thank you very much, Prof. Yes, thank you very, very much, Prof. We really enjoyed having you on, and we look forward to the next sessions. We are having them displayed there. So thank you very much, everybody, and have a good evening.
Thank you, Tania, and thank you, everybody, for your attention. And let's join hands to save these kids from.
Okay, everybody, good evening. Thank you.